Yes, good to go.
Hi everyone, I'm Dr. Priya Verma. I welcome all of you on behalf of Federation of Special Care Dentistry for our webinar of the evening. That's Periodontics in Special Care Dentistry by Dr. Anirudh Acharya. He's currently working at College of Dental Medicine, University of Sharjah at UAE. The session will be moderated by Dr. Shelly Pradhan, and I would just quickly introduce her to everyone. Dr. Shelly Pradhan is the first periodontist of Nepal, the senior most periodontist. She's also a chief consultant dental surgeon at and professor and head at Bir Hospital. She's board member, Medical Education Commission, Nepal, founder president of NSPOI, and a president of National Association of Dental Research. Over to you, Dr. Shelly.
Thank you, Dr. Priya, for this opportunity. Actually, I should congratulate you for this kind of event, like I had a very hard time understanding what is this special care dentistry, and you have brought it into perio. So it's become really interesting for me. So let me introduce, first of all, the chairperson of this session, Dr. A. Kumaraswamy. He has graduated from Government Dental College, Mumbai in 1979, and he completed his post-graduation in periodontology in 1982 from the same institute. Now, currently, he's working in Lalita Dental Clinic, and he has been, he has been going on with many international congress of oral implantology as their diplomate in 2003. I know him like from very close. We had him. I had opportunity to listen to him a couple of times. He's a really good orator, I must say. And he has brought perioaesthetics to the forefront of modern dental practice in India. And also he's the founder, member of the Indian Academy of Aesthetic and Cosmetic Dentistry, and is instrumental in teaching and training newer generation of dentists. And his passion for teaching and disseminating knowledge learned from his experience, and he attends a lot of conference. I have met him a couple of times. So welcome, sir, to this, to chair this session, to chair this webinar. Now, our next presenter for today's session, our own Dr. Anirudh B. Acharya. So I also know him since a long time, and we had opportunity to have him as our faculty in our one of the first dental colleges in Nepal. So many of your students are really excited to hear your voice, hear your presentations actually. Welcome, Dr. Anirudh.
Thank you.
So he is faculty, Department of Preventive and Restorative Dentistry, College of Dental Medicine, University of Sharjah and UAE, and he has done BDS, MDS in periodontics, PhD, and MFDS, RCPS from Glasgow, UK. And he has a range of publications in peer-reviewed international journals. He's also a reviewer to several international dental journals, and he was a section editor of Journal of Interdisciplinary Dentistry. He has held a variety of academic and administrative posts in his tenures and has been master trainer for dental faculty. And also he's a life member of several dental societies, and he has been invited speaker and has numerous national and international presentations to his credit. And I also met him as an external examiner in BPKHS Dharan for the first MDS batch who came out from Dharan. So I would really like to welcome you, sir, Dr. Anirudh B. Acharya, for your presentations to this webinar. And the title of his presentations is Periodontics in Special Care Dentistry and Overview. Now over to you, Dr. Anirudh. Thank you.
Thank you, Dr. Shelly, for those kind words. And shall I share my screen? 1 second. Yes, is it visible?
Yes.
Okay. Hello, everyone. And I feel very good to be in the august company of Dr. Kumaraswamy, who's a mentor to many, and he's a leading light in dentistry in India. So it's an honor. And of course, with Dr. Shaili Pradhan, a pioneer in her own right and an old friend and colleague of sorts. Thank you again. Now let's get this slide away. And it's happy birthday time. I've heard that today is the first anniversary of the Federation of Special Care Dentistry. So congratulations to the Federation of Special Care Dentistry, all the founders, the office bearers, the organizers, way to go. And it is my privilege to be giving the keynote on this special occasion. Thank you so much. Now, I think you must be familiar with some of these words. Just let it sink in. And some more. Now, the words in the red boxes are supposedly not preferred nowadays, whereas the words in the yellow boxes are supposedly politically correct and technically correct. But the point being that you have an idea now as to what community of people or groups of people we are dealing with tonight. And believe me, if we take into account rough global estimates, this community of people or group of people almost make up about 2 billion. You know, that's almost about 2 out of 8 people in the world are having some sort of a disability or a functional need. So we are dealing with something very serious. The Federation is actually doing a great job by taking up the initiative to address this very, very important concern, and so should we. So based upon this, I will be throwing some light and insights with regard to periodontics and SCD. I will not really be speaking about children, etc. But some of the pointers in periodontics which should, sort of make us more aware of how it can play a role or what kind of a role it can play when we are dealing with people with special care dental needs. Let me straight away jump into a case. The panel on your left is at walk-in, and the panel on the bottom right is at 5 months. Looks like a pretty straightforward perio case wherein the treatment has been done and there's good maintenance. But let me add a parameter here. This is a patient with glaucoma. And please note that glaucoma is a category 6 disability as put forward by the WHO. So glaucoma as such is having an unknown etiology in majority of the cases. And many a time, even after treatment, it goes into irreversible blindness. So unfortunately, so with this case too. But however, I would probably put this particular case as a sort of a success from a periodontal point of view. I shall come back to this particular case later with some more details because I'll just move on to a couple of more cases so that, I'll introduce you to a few aspects of we as periodontists or dentists in general would be encountering. Now, this is at walk-in. You can actually appreciate the gingival and periodontal condition. And on the bottom right panel, you see the same case after 1 month. So obviously no treatment was rendered to this case. Why? This is a patient with schizophrenia. Now, a very uncooperative patient. Of course, the patient was also institutionalized and had arrived to our facility with the medical attendant. But the patient was absolutely uncooperative. The only cooperation we got was when we actually told him that we would like to, take a picture of you and of your mouth. So that sort of pacified him probably, and he allowed us to put the, cheek retractors and things like that, and allowed us to take the picture. That was it. He did not allow us to go further. No examination allowed, not even the placement of a mouth mirror, nothing. It was extremely difficult. So the patient turned back, and we were in constant touch for some time. And after a month, the patient returned, and you can see that the case has actually, aggravated. The gingival condition has actually worsened. But then again, only the photograph was allowed. The patient was just unable to be coaxed into doing anything. And neither were the attendants, because I believe in this case, he was in a particular stage of schizophrenia, which was very, very difficult to manage, even by the psychiatrists. So the patient turned back. I mean, we had to do nothing for him, unfortunately. And shall we consider this as a failure from the periodontal point of view? I'm not sure, but maybe we will know the answer at the end, because it's very challenging. But for a small consolation, this was another case of schizophrenia responding to treatment, and was put in home care. And at the same time, this patient was also having hypertension and was on CCBs. CCBs meaning calcium channel blockers. So we know that calcium channel blockers do have an effect or influence on the gingival tissue. But however, in about 2 months after consultation with the patient's physician as well as the patient's carer, we were able to manage to bring the patient's gingival condition to a stage of stability. And in 2 months, it was quite a nice outcome. Of course, after 2 months, the patient relocated, but we did not get any feedback after that. But however, even with respect to this patient having schizophrenia as well as a comorbidity of hypertension, there was a particular approach which actually succeeded in at least lessening the patient's gingival problems. So based upon this, what is special care dentistry? And as per the definition, the improvement of oral health in individuals and groups in society with physical, sensory, intellectual, mental, medical, emotional, or social impairments or disability, or more often, a combination of a number of these factors. This has been provided by the Joint Advisory Committee for Special Care Dentistry. And if you can just reflect back upon the introductory cases which are put forward to you just a while ago, certain words in this definition are covering those conditions. We've had a case with a sensory disability, with a mental disability, with a medical disability, and an emotional disability. So all in all, special care dentistry encompasses a very wide range of disabilities, which we need to address as well as possible. Now, I shall take you through this presentation by posing some questions, both personal as well as from the literature. The first question is, can periodontists brush aside special care dentistry? Obviously, the answer is no. Why? These are some of the questions which give us the answers. Is periodontal disease worse in people requiring special care? Yes. There has been unequivocal evidence that periodontal diseases are worse in people with genetic and medical conditions, physical and sensory disabilities, stress, depression, mental and psychiatric disorders, learning difficulties, as well as social impairments. The next question, is periodontal disease more prevalent in such people? Again, the answer is yes. We all know about Down syndrome. People with disabilities of the limb, visual impairments, people with rheumatoid arthritis, Parkinson's disease, these come under as examples for physical and sensory disabilities. Social impairments, which include people who have a lower socioeconomic status, as well as people who are homeless. Schizophrenia, an obvious example for mental illness, and the aging population. We do require to recognize the aging population, because more significant is the depression in cognitive abilities of this group of people. So, of course, from a periodontal point of view, we do have probably sections and topics and chapters in the literature regarding geriatric periodontal care. However, the aging population will also be coming under the category of special care dentistry. And we as periodontists have been handling, medically compromised patients, and it's almost come off as a sort of a routine, treatment planning for such patients. But we also have to take into consideration that even these medically compromised patients will be categorized under special care dentistry patients. Next question: how does periodontal disease impact quality of life in such people? Apart from the functional aspects, aesthetics is affected, because we are dealing with the people who already have some impairments. And if there is periodontal disease, and of course to a certain extent other oral diseases also, aesthetics is affected, which in turn leads to the expression of emotion being affected, leading to physical and psychological discomfort. All this results with respect to poor health, which isolates such people. When there is an isolation, they sort of withdraw. If they withdraw, it becomes difficult to integrate them and accept them in society. So yes, periodontal disease does impact quality of life. And in the recent past, there have been a lot of studies and surveys regarding not just periodontal disease, but dental treatment as such, having an impact on the quality of life, not only in special care dentistry, but in the general population. So we do need to take the impact of oral diseases, periodontal diseases to be more specific, with respect to the impact it has on the quality of life, especially in people who require special care. Now let's take into consideration something which are generally, which you come across in the literature. Down syndrome, I wouldn't go too much into it, because we know that as such, people with Down syndrome have a propensity for gingival and periodontal diseases. There is aggravation because of various factors, including tooth morphology, the existence of mouth breathing. They are unable to maintain their personal hygiene, and at the same time, the inflammation worsens the condition. And there is a high possibility that they become toothless by, say, the fourth decade. So from this point of view, cooperative relationship with the carer is extremely important. If you probably come across a patient with cerebral palsy, you will probably do some adjustments with respect to the treatment when the patient is on the dental chair. You'll have to make sure that you don't force the patient into a position which you desire, but as well as ask the patient to settle down in a position which is comfortable to him or her, and making sure that you observe the patient's movements at all times. Because at times you may find the patient is making some jerky movements, but this does not actually imply uncooperative behavior. It is just that the patient will be reacting in such a way. So you will have to actually adjust accordingly. Gag reflexes are expected in patients with cerebral palsy, so you'll have to take care of that. And in addition to that, again, a cooperative relationship with the carer is very important. If patients have hearing loss or deafness, or what we sometimes refer to as auditory incapacity, you may come across patients using sign language or lip reading. Of course, with the patients who are having partial hearing loss, in the operatory, try to reduce the background noise, maybe suctions, etc. Speak slowly, loudly, and clearly. Of course, removal of masks is preferred for this, but now it's the time of COVID, so that becomes difficult too. And yet again, communication with the carer is important. Visual impairments, especially with respect to partial visual impairment, again speak slowly, loudly, and clearly. It would be preferable if you can actually explain how each dental equipment sounds like, because visually impaired people will be relying more on their auditory capacity. So if you can tell them how the scaler sounds or how the rotary instrument sounds, it will probably give the patient a better, relation to the procedure. And in addition to that, most importantly, you should always tell the patient whenever there is our aerosol spray. Now, even for example, if you have your eyes closed and there's a sudden mist of water, you will have a sudden reflex. So you can as well as imagine a sense of alarm a visually impaired patient on the dental chair would have if no forewarning has been given regarding an aerosol. And at the same time, communication with the carer is very important. Now, the next question, how is the outcome of periodontal care in such people? Now, this is a very difficult question to answer because we do not have comprehensive data. And you do have so many studies which compare, say, for example, Down syndrome with other mental disabilities, and they would probably suggest that people with Down syndrome have got more clinical attachment loss. Edentialism is probably reached faster as compared to other mental disabilities. But you still don't have much of data regarding how would periodontal care result in such people. There has been one study which indicates that periodontal disease prevalence increased over a 12 years period, and this was done in a group with learning disabilities. But however, there was a decrease in caries experience. So there's limited data regarding the outcome of periodontal care in people who require special care. But however, this particular one study, this 12-year study which I've just put across to you, is suggesting that increased periodontal disease prevalence. So we have very long-standing preventive care to take care in such people. Does access to care influence provision of care? Now, this depends upon whether the patient is institutionalized or at home or under the constant care of a carer. If you reflect back on some of the cases I introduced you to, we've had cases wherein one was institutionalized, one was at home, and the other one was under the constant care of a carer. But even with respect to an institutionalized individual, it was difficult to actually get to treating him. But with respect to the patients who were under the constant care as well as at home, we found that the outcomes were better. So it doesn't really probably matter unless and until all the stakeholders who's involved with respect to the patient's care, including the patient, are available for direct access to dental care. Another important aspect which actually governs the influence of periodontal care is the severity of the periodontal condition as well as the associated medical status. The associated medical status sometimes takes precedence and becomes very difficult to control, which has a direct impact on the periodontal condition also. Then we have the level of the skill set of the treating dentist. Now, it is not necessary that all patients need to be referred to a specialist. One would need to know how much of a treatment is beyond his limitation and then take the clinical call. But whatever said and done, a team approach is always required. Now, coming to a general perio workflow, which can be adopted, it's not much of a difference with respect to our regular patients, but how a perio workflow would entail the history taking, examination, diagnosis, non-surgical, the emergency management, then the non-surgical, the review of the treatment, maintenance, the surgical aspects, and most importantly, the preventive aspects. That forms a central core of the perio workflow in maintaining and treating such patients. We can probably have a sort of a card like this so that you can jot down your notes with respect to such cases. You can keep it separate so that you do not mix it up with your other case files. Of course, you can do it the way you want, but these would probably be the important aspects which you'll have to take into consideration. Now, I'll just be brushing upon a few of the important aspects in each of these, which you need to be slightly aware of and more attentive to when you come across such patients in your facility. History taking, again, I reiterate, communication with the patient as well as his or her carer is extremely important. The other thing is the medical history as well as the medications the patients are on. Please make sure that the patient or the patient's carer gives a very correct detail of history of pain and discomfort, and also make sure as to what are the oral hygiene habits of the patient and whether the oral hygiene habits are with or without assistance. Coming to examination, please remember that the examination may require more time and multiple appointments. Again, with that uncooperative patient with schizophrenia, which I had put across in the beginning, chairside assistance is always required. Uncooperative patients, morphological aspects like an enlarged tongue, physiologic aspects like gag reflexes will definitely be detriments. So you will have to be ready for such issues when you're performing the examination. And of course, if the patient does have past dental records or periodontal charts, these will be a bonus. The diagnosis is influenced by the medical condition. That's very imperative that you actually know what kind of a medical condition the particular patient has, because it has a direct bearing on what diagnosis you're coming to. And dental manifestations of syndromes. Now, there are so many syndromes. One would not be knowledgeable about all the syndromes. For example, if a patient comes to you with a history of, say, Candle syndrome, you wouldn't probably know. I wouldn't know. Because Candle syndrome, I think, is one of the rarest syndromes in the world. Probably about less than 100 cases have been, reported, and they do have oral manifestations. So if we come to such a point, we need to be more knowledgeable about that particular condition. Probably take the help of experts, read up, and then address that particular patient. So you never know what kind of a patient with what kind of a syndrome will be up at your door. So of course, from a periodontal point of view, the biofilm plaque retentive factors are going to be a major will be playing a major role on the diagnosis as well as later on in the prognosis, as well as a note on the parafunctional habits. Emergency management always give first priority for alleviating the patient's pain and infection. If systemic antibiotics are indicated, especially in immunocompromised patients, please prescribe them. And if it is beyond, it is always practical to refer the patient to a specialist care in a hospital. Non-surgical periodontal therapy will also, needless to say, require multiple appointments. Now, if indicated or preferred, general anesthesia would be practical, because if I go back to that same uncooperative patient with schizophrenia, we actually suggested to the psychiatrist that since the patient is so uncooperative, why don't we do it under general anesthesia? Now, the psychiatrist, along with the anesthetist, were not willing to give the clearance for the simple reason that the dosage and the type of antipsychotics the schizophrenic was actually, being administered would probably lead to certain side effects, especially peri-operative when the patient is recovering from the general anesthesia. So these are also, the challenges which we tend to come across with actually, little support from anywhere. So it becomes very unfortunate and dissatisfying that we couldn't do anything much. Apart from that, in the non-surgical therapy, if there are teeth with very poor prognosis, you can as well as remove them. And by and large, if there are other dental treatment for the patient, be in sync with the other specialists and make sure that the periodontal care is in sync with the overall treatment plan. Review of the treatment should be as per the literature in every 3 to 6 months, but I would suggest it has to be earlier. I would suggest after completion, at least at a month's time. Make sure that you reevaluate the oral hygiene, smoking history, medical history, dietary habits, etc., and make sure you update the changes in the medical records. Maintenance therapy, recall visits should be scheduled as per the influence of the ability to control plaque by the patient. Very important, involve and support the patient as well as the carer to maintain oral hygiene. The surgical treatment, most of the time, it would probably be excision of the gingival overgrowth, which will facilitate biofilm control. But however, it is a surgical treatment which needs to be discussed with the patient as well as the patient's carer. But we have to ensure that excellent home care has to be established before we undertake any surgical procedures. And again, during the time of the surgery, if you again find teeth with poor prognosis, can as well as extract them. This is the most important periodontal aspect in special care dentistry, the preventive phase. Not only is it important, it's very, very challenging. Now, we as dentists, we as periodontists do have our operative skills. No questions about that. But when we come across patients who require special care, we need to go a little bit beyond our operative skills. We need to communicate, we need to interact. All those basics which were given in our textbooks of perio, education, motivation, instruction, take a different meaning altogether, because you have to customize it based upon what kind of a patient you're dealing with, what kind of a carer you're dealing with. This becomes extremely important, and there is nothing in the books that will teach you this. You will have to customize it based upon your own logic, experience, etc. But however, by choice, apart from customizing the oral health, education, and preventive care, use of tools or aids to educate the patient or the carer is going to be extremely helpful. Now, let me give you an example. It goes without saying that we usually tend to use a toothbrush and models to explain to the patient or the patient's carer regarding how to brush, etc. But sometimes I feel that the patients in this special care category do not really relate to the models. It's very difficult to put it across to them. So you'll have to think about something else. I would probably suggest reading material. There's some material which has been shared with me by the Federation, which I'll be putting across slightly later. But at the same time, videos do help. Please make sure that you have instructional videos, because instructional videos, especially for the ones who who do not have any visual impairments, will be very helpful. Make sure that the instructional videos do have subtitles, and more importantly, it has to be in the language of choice. Now, we do show all these videos in English, etc. But if it actually has to reach the end user, it has to be in the language of that particular patient's choice or the patient's caregiver, because sometimes videos do not work for the patient directly based upon the disability he or she is having. So from that point of view, it has to target the carer. So that makes the carer understand what he or she has to do for his or her patient. So that becomes very important. And at the same time, you will have to accept the patient and the carer's limitations. Now, at times you might come across the carer not really being very educated. So you will have to probably go the extra mile in actually educating the carer more than the patient. So all these are things which are, a part of a learning curve, which comes from patient experience to patient experience. But however, you cannot ignore that interactions with others associated with the care of the patient is also extremely important. Now, if I can put this picture for you, a good old disclosing agent actually works wonders because the patient is seeing fairly white teeth, and suddenly after the use of the disclosing solution looks at the change and is actually quite aware that there is something wrong. You have to constantly keep using such tools or aids to educate both the patient as well as the carer. And these were some of the educational aids which were shared with me by the federation. So this is quite nice, but again, this has to be in the language of the patient or the patient's carer's choice. So that is extremely important. And certain descriptive visuals regarding how the carer can actually take care of the patient in cases of severe disability when the patient cannot manage on his or her own in maintaining oral hygiene habits. What would be certain recommendations? You can recommend color-coded toothbrushes, manual toothbrushes, including the Collis curve, the three-way electric toothbrushes, interdental brushes, mouthwashes, of course, dental floss. But again, I have my reservations with the dental floss in some cases. I'll throw some more light onto that in just a while. Very important, demonstrate and assist the patient or the carer to access the mouth for good oral hygiene practice. Now, it's always a very, very, simple and effective way of asking the patient to get, or the carer to get his or her own toothbrush. Use the toothbrush on the patient or the patient's carer. Make sure in case of severe disabilities, for example, if the patient has got a severe disability wherein it's just impossible for him or her to access his or her own oral cavity, it is the responsibility of the carer to do that. And if the carer does not know how to take care of his or her own oral hygiene habits, then it's going to be an exercise in futility. So you will have to make sure that you train the carer. The carer has to be trained. Our job is half done once we actually do a scaling, a polishing, a small surgical maneuver, whatever the case may be. The other half is entirely with the patient and the patient's carer or the group of people who are associated with, in proximity with respect to the patient's oral hygiene habits. If the patient at times has some deleterious habits like smoking, make sure that that is an added component which has to be taken care of. So make sure that it is addressed appropriately. And if there are any aberrant oral habits, make sure that is taken care of appropriately. At times, there could be referral required for nutritional and diet counseling. So that also can be done. Now, these are few of the pictures of the toothbrushes, special types of toothbrushes which are available. The one on the left is what we call the Collis curve toothbrush. The one on the right is the sonic bristled three-way toothbrush. Just to give you a slight initiation, or of course you will be knowing about this, but for the benefit of the ones who do not know, let's see if I can play the next video regarding the Collis curve toothbrush, which was again provided to me by the federation. This is an added thing which I would suggest. I am not uh, in line with this particular company, but there is something called as the ITOP, which was first put forward by Dr. Eri Sedelmeier. ITOP basically stands for uh, individualized. Why am I missing this? See, I'm forgetting the T. I've gone through this training and I'm having a block here. Individualized trained oral prophylaxis, ITOP. Okay. Now, I went through this particular course a couple of years ago. At the outset, it did not sound so attractive. It required a lot of implements, etc., etc. But after that, I realized that this particular ITOP program is extremely beneficial if we can actually train the carers in taking care of the special care dentistry patients. Why am I saying this? This is just a suggestion so that you can probably think about it, or anything in league like this. So there are a lot of different diametered interproximal brushes, and I found that these fit in very nicely, customizable to the particular area. You can use one for the anteriors, two for the anteriors, two different types of the anteriors, and different ones for the posteriors. So you have a range of such interproximal brushes. But it actually requires you to train the carer on how to use this, because I feel that instead of the dental floss, the carer would probably be better, trained and well versed and more comfortable in actually using these type of brushes in the interproximal areas of the person who's having the disability. And we know, I mean, from a cursory point of view, that the interproximal areas account for roughly about 40% of the tooth surface. And we also know that from a periodontal point of view, that the interproximal area is the portal of entry, for periodontal diseases. So it becomes very, very important that the interproximal areas are actually taken care of in such individuals. So this may not be for all the disabled patients, but I would probably suggest that such a training can be given to the carers. I'm not talking about training from a comprehensive point of view. We get an orientation and a sensitization to the use of such customized interdental brushes, and then recommend this to the carer and spend some time with the carer, teach the carer how to use it on himself or herself, which can sort of be replicated by the carer on the patient over a long-term basis. So this is one suggestion which can probably have a fairly good impact in the preventive phase in taking care of patients with requirements of special care. Okay, fine. I'll take you through some case files. Okay, this patient is my colleague's, not mine, but anyway, I found it interesting to put it across to you. The patient, again, a schizophrenia patient, came with the fear, along with the carer actually, came with the fear that this particular enlargement could probably be a cancer. Of course, the diagnosis was inflammatory gingival enlargement. So the excision of the gingival enlargement was done. A consultation with the psychiatrist and the assigned social worker as well as the nurse was done. An oral prophylaxis was also done. Review after a week or 10 days resulted in uneventful healing. But then the patient, I believe, did not turn back. And after communication of about 6 months later, total clearance of the teeth was reported. So here, except for the emergency management, which I put across in the protocol in the beginning, nothing more could be done. The patient went in for a total extraction in about 6 months' time. So again, challenging. cannot say it is not successful. From a periodontist point of view, at that point in time when the patient came in with this chief complaint, the treatment was rendered. But from the point of view of the patient's illness, the patient's care after the patient left the dental office was not really in our hands. So this becomes challenging. This is a patient who had an upper limb disability, wherein he actually lost his right hand in an accident. In addition to that, he was having type 2 diabetes mellitus. And until then, he was having self-care. Now, when he came in, we diagnosed it as periodontitis with multiple abscesses influenced by T2DM. So the initial emergency management was the treatment of the abscesses. But we did the non-surgical treatment of oral prophylaxis, and then we recommended to this patient the electric toothbrush, because now, considering that he was a right-hander, he was brushing his teeth all these years with his right hand. It was going to be very difficult for him to suddenly, start brushing his teeth with his left hand. So we recommended the electric toothbrush, and at the same time, because he had lost his dominant hand and he required to use his left hand for his daily chores, he was consulting with his physiotherapist also. So in fact, I believe the physiotherapist was sort of training him even with respect to writing, with his left hand. So when this sort of adjustment and coping mechanism was going on in this particular patient, we threw in this electric toothbrush as a good tool, so that it will be easier for him and he can actually do it himself. And with a lot of effort and self-motivation, the amount of self-motivation this patient had was pretty amazing. And look at the results. The photograph which you're seeing is at around 5 months, 5 to 6 months, but it was amazing. He was able to manage without help from anybody with respect to oral healthcare. That is what I'm trying to say. But by using an electric toothbrush with his left hand, it's pretty amazing, and we felt very proud. And at the same time, he was in constant consultation with his physician, because we made it very clear to him that there is a connection between his hyperglycemia as well as its effect on the gingival and periodontal tissues. So I found this pretty remarkable. Uh, I mean, we give them special care and they come back as heroes. This is what I would probably say. It was touching, and it was actually a sense of success and pride, from a clinician's point of view. But hats off to this patient. So that is where we can, as periodontists, these could be simple things, but this has gone a long way. Just look at the results with respect to the photograph on the left and photograph on the right. It's what we look for, it is what we strive for, and the patient has done half the job, and with great success. Amazing. So this was one patient I found interesting to share with you. This was another younger patient with an intellectual disability, who required constant assisted oral hygiene care. Came in, and the diagnosis was generally it was periodontitis. Patient was cooperative from the point of view that he was submissive, so to speak. So he was in agreement because he had total trust with his carer. So whatever the carer told him, he would submit to it. Submit to it in the sense, I would say, be cooperative about it. And we actually did the oral prophylaxis, and since a couple of teeth had a very poor prognosis, we had to extract those teeth. And by about 2 months time, with the oral prophylaxis done in multiple appointments, it took I think about 3 appointments, we got a fairly good result. But after 2 months of the last review, we lost the patient to follow-up. The patient didn't turn back, but at least at the time of our last interaction with the patient, the gingival and periodontal condition was quite good. But then again here, the carer played a very, very important role. Now, this is where those pictorials which were shown to you, the educational material which was shown to you in the previous slides, really do matter. And in addition to that, to supplement that, demonstrating this on the carer's own mouth makes a huge, huge difference. And this has to be done by us periodontists. We are the brushers of the dental fraternity. So we can't shy away from this. We can't give excuses that we do not have time, we have another patient waiting and things like that. So we will have to be extremely patient and spend a lot of time to gain the desirable outcome in such patients who, from my point of view, require the best quality care that can be provided to them. Because we feel small when they show such motivation and interest in bringing about successful outcomes to their own oral hygiene. It gives a very great sense of satisfaction when such kinds of patients come to you with a smile, which is more than anything else. So that was amazing. And I told you in the beginning that I'll be coming back to the glaucoma case. Here the patient was unable to see. So from that point of view, the patient's spouse was the most important cog in the wheel, along with the family support. And of course, from the dental and medical side, as much as possible was done. Of course, we from the perio point of view did the routine therapy what was required. But it was the patient's spouse who took up the cudgels in making sure that the patient's oral hygiene is maintained. So from my point of view, as I have been reiterating from the beginning, in such cases which require special care, it's very, very important to identify who the patient's carer is, whether it is from an institutionalized point of view, whether it is from a home care point of view. Identification of the spouse, identification of the spouse, identification of the carer, identification of the family, developing a great rapport, motivating these people to be of great worth and value in making the oral care of these patients successful. That's very important. So in all the cases I've presented to you so far, from one point of view, I would say that this particular case is probably the most successful, because there was an equal sort of, it takes two to tango. So we did the tango, and the spouse of the patient did the other bit. It was pretty amazing. So with respect to the cases, I would want to leave with this particular case as one of the most valuable ones which came across. Now comes the next question: can periodontists brush? Is it a funny question? Maybe it is, but the point is, we have come across the recommended brushing techniques when we got into our undergraduate days. Till then, we were brushing the way we were brushing, unless and until we've had an experience with a dentist before that. But we all realize that if there is a requirement for changing the brushing technique in ourselves, it takes a lot of effort. Have any one of us used this Collis curve brush? Do we know how it feels like? Can we relate to it before we actually tell patients who require special care and their carers that this is how it will feel? No. So we need to, and it does not necessarily mean that it has to be the Collis curve toothbrush. It can even mean a change in the brushing technique which you want to incorporate suddenly. Say, for example, suddenly there's a progressive gingival recession in our mouths, and we probably have to make some changes. We as dentists and periodontists would probably find it a bit challenging. Then just imagine how it would be for the lay person and for people who require special care. So we need to really, really do a lot more. So can periodontists brush? Yes, we have to. And that is where it comes into the picture with respect to maintaining periodontal health. Number one, more patients visits generally increases patient cooperation and compliance. So make sure that you actually call the patients more number of times. Sometimes, as I've given one example, it may be futile, but it will work. empathy towards the patient. Now, the patient will be having a lot of factors which, may be requiring empathy. But empathy is not learned, I believe, according to some experts. It can be facilitated. Now, at the same time, all of us in the dental fraternity will not be having the same sort of empathetic levels or values towards our patients, irrespective of whether they require special care dentistry or not. Now, from that point of view, I would probably say that if dentists lack empathy, there are a lot of disabilities which have the clinical feature of lacking empathy. So do we need special care? So we need to actually make sure that we facilitate our empathetic values. If we do not have that, then it becomes very difficult to relate to such patients. The next one, yes, Dr. Priya, time up. The next thing is going into having the basic knowledge of various disabilities, making sure to a certain extent that the patient's waiting period during the appointments is less. All this might, sort of lead to better conservative treatment rather than extraction. Make sure that the patient follows a home care program to enhance oral care as well as treatment outcomes. Make sure that you note any physical and medical limitations in the home care. Oral hygiene instructions require education and training for the patient as well as for the carer to achieve the desirable outcome. I'm repeating this again so that it drives home the point. Consider the patients and their carer's motivation, and a very proactive relationship with the patient's carer is important. These are some of the barriers in maintenance care. I think I'll have to hurry up. So disinterest in oral hygiene, loss of tactile ability, chronic stress which affects immune response, adverse habits like smoking, physical and learning disabilities, and frequent change of carers. These would be barriers in maintenance care. So in a nutshell, be empathetic, have a basic knowledge of the underlying conditions which require special care, make sure that you have effective communication, proactive interaction with all the stakeholders, recognize your own limitations in the delivery of such care, and have to have a team approach. These are some of my selected references, but at the same time, I would like to end by saying that there is no I in team, but the Federation of Special Care Dentistry does not have one I, it has three. Three, which include inclusion, involvement, and integration. And hats off to this particular thing. Inclusion, involvement, and integration is extremely important for teamwork. So my congratulations to the FSCD on their first birthday, and wishing them lots and lots of successes in the years to come. And three cheers to your teamwork. Remember, prevention is the key. A skill mix is our special need. That is we as dentists. Thank you very much. And I hope I didn't take too much time. Yes, I'm done.
Thank you, Dr. Anirudh, for such a wonderful presentations. You have made it so simple. Basically, the three things I have learned is you have to be very empathetic, you have to be very communicative, and you have to have a team approach through your presentations. Now, there are many questions, a couple of questions in the chat box, so you can just go through that. We will be discussing about the questions a little later. Then I would also like to welcome President of this FSCD, Dr. Srinivas Namineni, in this webinar. Actually, I should have done it before. Sorry for that. I didn't know his name, so I took quite some time. Now, I would like to request our chairperson, Dr. Kumaraswamy, sir, to highlight on FSCD and the scope of periodontics in SCD. He has been working in this area since long, so over to you, sir. Thank you.
Thank you so much. Thank you very much. Good evening, everybody. You know, at the outset, I was just looking at the number of participants at the lower horizontal row. And what amazed me was, over the past about 1.5 years, I was mentioning before this show started, that we got webinars coming out of our ears, and people probably have seen it all. But today, from the time that the webinar started, and yes, Priya, you really deserve all the kudos because the number is only going up. Not a single person has left the meeting. And it only speaks about you as an organizer, the way you have reached out to people, to Dr. Anirudh, the way he laid out the entire content so beautifully, and the involvement of each and every person who has logged into this meeting. Like Dr. Shaili was mentioning, it was, I think, in mid-90s that I stumbled upon an opportunity to be associated with a school for special care. And thanks to the support of my family members and my profession, that I could start a small dental clinic in that school for special care. Just about 3 or 4 years, and then of course the legendary Dr. Santosh Ravindran stepped in, and till today he's in charge of maintaining and running that center along with 2 of his colleagues. And what we noticed there is these children got wonderful heart. They got an excellent mind. Yes, I call them children of a lesser God. So a few things have been what I say as differently abled. And on the larger canvas, all of us are differently abled, aren't we? So if you were to associate a person with limited ability towards oral care, then we have a large spectrum to fit in there. And why do I say this? There is a dotted line between geriatric care and special care. Yes, geriatrics, whether they are completely sound of mind or suffering from dementia and Alzheimer's and age-associated issues, also fall into the category of special care. Probably easier to treat. Like Dr. Anirudh said in his presentation, we need to understand, we need to connect. And a lot has been said and heard, and we have a very mature audience today, so I will not delve deeper into what we need. Yes, we need a lot of patience to get across to this segment of people. If they are scared, and when I'm talking about normal patients, how many of them would voluntarily walk in for scaling? I don't need the answers, you know the answer. How many of them would walk in for care of soft tissue, their gingiva, their periodontal condition? Few, because the bane of a periodontist is there isn't pain to propel and drive the patient through the doors of dental clinics. If this is what normal patients suffer from, what can we expect from these recipients of special care dentistry? Yes, we need to take the extra step and walk the extra mile to ensure confidence in the minds of the carer, like Andrew rightly meant. We need to first connect with the carer. And because these children have immense confidence in the carer. They could be parents, or they could be teachers in the special schools, or the special brand of the Nightingales, the carers who take care of these children, and of course, adults. We need to connect with them. And what I've also realized and experienced is that if we can make this into a game for these children, they embrace you. They remember. So the first few meetings is only to get their confidence and love. And once they connect with you, you know what really moved me was, there was a break of about 4 or 5 weeks because of some vacation. And when I went back after those 5 weeks, at the gate of the school, they came running and in their own way expressed recognition. And that moves you. Once you connect, we always say in practice management terms that word of mouth gets you more patients. And once you make the patients comfortable, they get hooked onto you. They will not go anywhere else. The same thing holds good for these children as well. We need to spend time. We need to understand them and make it very light. Do not drag them into the operatory. If at all you're blessed with good space, sit with them, chat with them, let them play with you. You play with them. This is what is required, and for which you need to have a soft heart, which I'm sure most of us have. And we also will have opportunities. Grab at the opportunities. How do you create opportunities? I'm sure if you are into practice for 5 years or 10 years, you'll have a huge clientele of patients. Through their relatives, families, and friends, you can send a message that this weekend, select a weekend, our clinic is going to ensure that we are going to treat and care for people with special care needs. Could be an adult, could be geriatric, could be a child. So the message goes out strongly that here is a dentist who cares for these special care people, who has set aside days, who has set aside SOPs, and he with his team will ensure that we will do this outreach within the reach of our clinics and practices. There is a huge role for periodontics, and I will not be selfish here and say that please concentrate on perio. Concentrate on what that person needs inside the oral cavity. Glance, once he allows you to inspect. That's a challenge, by the way. Don't think that and I'm so glad Dr. Srinivas Garu, Namineni Garu is here. He, with his message of conscious sedation, is indeed the solution. We may slightly stay shy of conventional anesthetic procedures and adopt conscious sedation, minimize the visit for treatment. And normal patients, we know, once you sort of create some discomfort or pain, they stay away. They knock some other door. You don't want the same thing to be happening to these children. So try to give them a lot of love and compassion. And I'm sure we all have it in us. Only thing is, we need to set aside some time. So on this auspicious occasion of the first anniversary of FSCD, I would love to compliment all the people, the founding members, who went beyond the call of duty and created this federation. Because I was just talking to Dr. Priya and Dr. Shaili. We need to put our heads together, use our good offices with the Dental Council, with the regulatory authorities, that let's sensitize an undergrad student. Let's sensitize interns so that when they start their practices or work in big hospitals, they're already aware that I need to do something extra to reach out to this recipient of special care dentistry. Let's take it as our mission. You know, when I started, like I said, in mid-90s with the center, little did I know that 30 years down the line, and it's taken 30 years, it should have taken less, but for whatever reason, let's now not look back, but look forward with confidence and hope and create a buzz and within your own sphere. And that's how, like they say, log judte jayenge, karwa bante jayega. So thank you very much. Congratulations. And thank you, Priya, for this opportunity. Wonderful presentation, Anirudh. And thank you, Dr. Shaili, for all the courtesies extended. Thank you.
Thank you so much, sir. It was so lovely to get that insight from you. And these words are really valuable to us. And welcome, Namineni, sir. And I would, as Kumar sir mentioned, that a little bit insight on sedation would be really a great help to our audiences, especially from the perio perspective. And they're pretty new to all these things. So if you could just shed light on a little bit of sedation, use of sedation in special care dentistry.
Thanks, Dr. Anirudh. It was wonderful listening to you, and it was amazing. You know, as Dr. Kumaraswamy was mentioning, the number speaks all. It's always pleasure to listen to you, sir. You know, you are such a role model to everyone, and your kind words mean a lot for all of us. As you said, Priya has put a lot of efforts, and Srikanth, and they have put a lot of efforts in bringing everybody together. And before we go further, I'm sure, as Dr. Kumaraswamy said, sedation is going to be of immense value in dentistry, and more specifically with the children with the special needs and adults with the special needs. It basically alleviates the person from anxiety, and it's one of the safest ways to make the child or adult comfortable when they're especially suffering from any kind of special needs situation. Thanks for making a mention of it, sir. I'm sure that would definitely make people aware and be motivated about adopting sedation in mainstream dentistry. Thanks, Priya. Thanks very much. And it was wonderful to see all of you on the podium.
Thank you, sir. We would now go ahead and take the Q&A. Dr. Sherry will take the Q&A session with Dr. Anirudh.
Yes. Thank you, Kumaraswamy, sir, and thank you, Namineni, sir, for such a wonderful insight. And of course, we had a very wonderful, excellent presentation by Dr. Anirudh, and he has made it so simple. I saw a couple of questions. Have you gone through that, Dr.
Yes,
Anirudh?
yes, Dr. Haley. I would probably, ask for forgiveness with respect to some questions regarding children. I don't think I would be the right authority to speak about that. So apart from the question on children, I will take the others. I think one of the first ones is the carer himself or herself is under stress. So how do we manage to motivate the carer? So my question to that question is, what is the relationship of the carer to the patient? If by chance, if it is a family member, not much can be done about that. But if it is a carer who is not a family member, then needless to say, an option of changing the carer has to be considered. I hope that answers the question, because if the family member is the carer and is under stress, then there are a lot of other things which need to be addressed with respect to that carer. So
I would like to answer that, sir, for you. Most of the time, what we have seen with the special care, this question actually seems to be very hypothetical to me, because most of the times the patients and the carers I have seen is the carer adjust very well. If the carer is coming along with the patient to the practice, 90% of the time they are already adjusted and they know the needs of the patients very well. So the stress of the carer can be seen in the very, very initial stage of the diagnosis. Thereafter, the family adapts to it really well, and probably they are a more important source of information than what we can give. They give us more information how to handle the patients. So for me, this question is very hypothetical. The stress may exist, but at a very, very initial stage. Thereafter, the family remodels their mind and adapts to the situation.
I think, Dr. Prey, you got that right, because at the end it is about the carer. Caring is for the child, not an adult. So I think you have answered the question, irrespective of whether it was hypothetical. Yes, sir, Kumar, sir.
May I step in?
Yes, sir, please.
Thank you. So what I would suggest is using our TSD technique, tell, show, do. If you feel that a patient needs attention but is not cooperative and he's having some reservations and fears, just bring him to reception and let him just sit there and observe a normal patient being treated on the chair. Once, twice, thrice. That's the confidence build up. He knows that there's no shrieking, he knows there's no shouting, and the carer with the patient who needs special care attention will just visit the reception area. Let him just come and go. Of course, I'm not talking about a child with severe toothache and urgent attention. I'm talking about soft tissue care or a periodic cleaning. Let him just sit and watch. Or they identify another child with similar special attention and differently abled. All the patients are not difficult to treat. There will be few who will be easy to treat. When such a patient is being treated, call this other patient. Let him have a look. That is when they start getting comfortable and they'll allow you to treat. Just a small tip I can share.
Yes, sir. Thank you, sir. There's one more. This is again child. Among various types of modified toothbrushes, which one would be the most effective for a special child? So, Dr. Priya, you can take that.
I think initially they can go ahead. The carer should be trained for the techniques, and if there are any cognitive difficulties, or there is lack of most of the time the complications or the difficulty in brushing comes from the lack of the manual dexterity, or there are some cognitive issue, or the patient is on the persistent medications. So the lack of manual dexterity and most of the time the speech, hearing and the visual impairments are the one which causes maximum deterioration of oral hygiene. So if these are the problems, I think Colin curves is a very good answer to it. Colin curves and three-way brushing, it makes the life easier. Like in initial days, we didn't have a lot of brushes, but Colin curve brush and the three-way brushes are right now the answer. And instead of flossing, flossing can be made easier by water flosser. We have water flosser and air flosser in the market, and that makes our job a lot more easier and quicker. I think the other periodontists can comment on this.
Yes, that's fine. Yeah. That's agreeable.
Yeah.
The next question is with respect to affordability of interdental brushes in rural areas. Yes, actually, I actually wanted to put this as part of a point in my presentation. Yes, that is going to be difficult. See, and this particular aspect of economics and dentistry, with respect to any arm of treatment, is always going to be a challenge. So we can't really address this particular question with respect to the affordability and things like that from an individual point of view. But however, if by chance the interdental brushes are not affordable, then the conventional ways which have already been told to you about, that has to be implemented. We can't do anything regarding that, because affordability is always going to be a big challenge in this part of the world. So we really can't give a very unequivocal answer to that particular question. So any inputs from Kumar sir?
Yeah, so this is where I see a huge role for the federation. And how do we facilitate? The federation can and should, and I'm sure we can facilitate the stocking and supplies of toothbrushes. There are many leading manufacturers who would extend a helping arm once we go ahead and present to them that we need to reach out to these recipients of special care dentistry with this specially designed toothbrushes. And I'm sure they will help. I could probably help you. We'll take it offline, but I'm sure we can set up a facility where these leading, I don't want to name them because it's improper platform to name them, but we surely can facilitate the supplies to special school to begin with. We should, most successful programs today, they all began in schools 3 to 4 decades ago. That's what we did, right? We went to schools, we spoke to the children, we spoke to the teachers, and oral care programs were done. Similarly, we can set these up, and our members in the Federation, Pan-India, will be very happy, and we can set up these programs, and I can help you with this for sure.
I would like to add a point over here to the question asked. If prevention or using a toothbrush is considered as a roadblock, it must be understood that the disease, the treatment of disease comes at a higher cost and a higher burden to the society. So this is the minimum which you can do for the children at a very initial stage. And yes, availability. Sorry. Availability could be a question. The federation would certainly look into making it available, but and the cost also probably to an extent we would be able to look into. But prevention is something which should never be ruled out, because disease treatment comes at a higher cost.
Okay, thank you. Dr. Shaley, I'll just quickly go through. There are only about 1 or 2 questions related to perio. After that, there are, not after that, before that, there are questions only related to pedo. I think you can probably take up those questions and put it forward to Dr. Priya or anybody else who's, really interested to answer that. So one particular question is with respect to what mouthwash or toothpaste do you suggest is the best for maintaining good oral microbiome? Is the use of herbal containing mouthwash and toothpaste shown better results? Things like that. This is from Indonesia. The question is from Indonesia. Devi, how would I answer this? I would answer this in a traditional way, that though your question has a traditional component in it with respect to herbal, mouthwashes, my answer is going to be a very traditional way, that there is going to be no substitute for mechanical oral biofilm control. I think every periodontist would probably agree with that. All the others would probably be just adjuncts. And I think we've been going through this ever since we've started our dentistry. And I will not be suggesting which toothpaste or which mouthwash, whether it is herbal or whatever, which is the best. No, I cannot give you an answer. Nobody can give you an answer to that, because ultimately it depends upon the mechanical oral biofilm removal technique, which every one of us have to master. And I was emphasizing on this even in my presentation. So I hope that answers your question, and it's not disappointing, because usually we do have a lot of excitement when we ask a question and require, one magic bullet answer, but there is no magic bullet answer for this. Sorry to disappoint you, but yes, the magic bullet answer to this is mechanical plug control. And I'm just going through if there is any other. Yes, this is an interesting one. Use of edible toothbrushes. Will it be helpful in special healthcare patients? Yes, why not? But again, it should not be the standalone. Edible toothbrushes need not be the standalone. You'll probably have to look at how effective it is, because again, we can't give an umbrella answer to such questions. It again depends upon the particular patient, how the patient is able to relate to these edible toothbrushes, how effectively the patient uses these edible toothbrushes. Is it very effective? Have you evaluated its effectiveness on a case-based scenario? Yes, then why not? I will not say no to it, but it entirely depends upon your clinical decision after reviewing the edible toothbrush which your patient has been using.
But if we take it with the earlier point of affordability, then it's like
then it's fine.
Yes, yeah. So we need to be careful about that as well.
I guess that's the major perio questions. I shall just put forward. I'll take you back to the perio questions now.
That I will, I think.
Yes, Dr. Sherry, thank you
for that. Thank you, Dr. Anirudh. So there's one question by Kavya Shankar. For a medically compromised child, how can oral hygiene habits be modified for an ultimate good oral hygiene? Dr. Priya or anyone can, because it's
probably lost out. Can you just repeat it for me, please?
Okay. For a medically compromised child, how can oral hygiene habits be modified for an ultimate good oral hygiene?
Okay, so let's analyze the huge umbrella of medical compromise. Could any which way make it difficult to answer this? Unless we know for sure that we are talking about a patient with multiple comorbidities and with moderate control, then of course, the special care becomes even more special in such a patient. We are not compromising on the oral care. Other treatments will happen and should happen parallelly. And we will take this patient, for example, a patient who is in hospital, not necessarily ICU, in a hospital. And a special care patient in hospital will have additional care related to different faculties. Similarly, there, the lowest priority seems to be oral care, which we need to bring it up the ladder. So there, I think the role of the oral care provider becomes extremely important. We need to then talk to our medical colleagues. And that's not easy. That's not easy that even today, if we were to tell the doctor, look, the teeth and gums are more important, they said, look, heart is more important, the liver is more important. We understand that. But that being a challenge, we need to slowly work on them and make sure that oral care in these children, in this geriatrics, in such patients is equally important, if not more. That's how I would go about it.
Yes, Kumar sir, absolutely rightly said. Speaking to a medical consultant, it's so difficult. You won't believe it. One of a leading medical practitioner who I was speaking to about, dental and medical health, went on to say that you have 32 teeth. I've got just one heart to take care of. Well and true, but yes, but we have our own 32 to take care of, or 20 for that matter in the younger. Yeah, it is very difficult.
Certainly, we cannot deny the fact of importance of medical professionals, and we have to take care. The heart can fail anytime. The kidney might lose its functions. The tooth can.
Yeah, going on, taking off from the last slide that Dr. Anirudh shared, team. So where I find again a role for FSCD, and please pardon me for putting additional responsibilities on FSCD, is to create a task force.
Yes.
Our primary job should be to create a task force, and it has to be multiple members in this task force.
We are doing that, sir. We are at it.
Wonderful.
We are at it. Okay. So I would just like to take 5 minutes and do some announcements before we start awarding the certificates. Dr. Shelly, may I?
Yeah, sure.
Our first announcement for the evening is that we have launched our first specialty board, that's the autism board, and we would like to announce that. And Praveen, could you please play the video? Okay, that was our first board that we announced today. We shall be announcing the members in our next webinar meet. And till then, I would just like to say the autism board will be dedicatedly working in the area of autism. They'll be diligently working in the area of research, education, awareness. When it comes to autism, we'll be talking about various comorbidities associated with the and their effect on oral health care. And we wholeheartedly invite everyone who wants to be a part of autism. They are more than welcome to come and be a member with us and give their inputs and work with us. This was about the autism board. My next announcement is about Dr. Virender Goyal. Praveet, could you please have the slide on?
Yes, it is displayed.
Yes, so I would like to inform everyone and congratulate personally Dr. Virender Goyal, who is a global ambassador with us and a real hard worker and a go-getter. He is representing all of us globally, and he has been elected as a representative of a national member society in International Association of Pediatric Dentistry. And over it. He's the first member from the South Asian region to be elected for this post. Congratulations, sir. FSCD is really, really proud of you. My next announcement is about there have been a lot of people who've been helping us in background and to achieve what we are trying to achieve. So we just wanted to take a quick moment to acknowledge them. So Praveen, could you please put the certificates on? So. Praveen, are you there? Could you please take it also? Yeah, so our first certificate of appreciation goes to Isha Verma. She is a lovely child who delivered us a small talk on her journey of life during our inaugural ceremony. Can we have Isha? Isha is there with us. Can you please, Isha, can you please turn on your camera? Isha. Hi, Isha. Congratulations, Isha. Thank you so much for being a part of us.
Hello, everyone. I sincerely thank Federation of Special Care Dentistry, Dr. Naminini Srinivas sir and Dr. Priya Verma ma'am for this honor and all the love. Thank you.
Thank you, Isha. We are so glad to have you around. Praveen, could we please have the next certificate on? Can we have Sneha? Sneha, are you around? Okay, so Sneha Tulsani, she is a lovely girl. She's a periodontist by profession, and parallelly she is she does a lot of wonderful fashion illustrations. So I was looking for someone who could create a banner for us and who could at the same time understand what we really wanted to put across as a disability. So Isha helped us, Sneha helped us creating that banner for our website, and she has very beautifully, she has put across the concept of special healthcare need across all the ages and across all the races and all the disabilities. Thank you, Sneha. It was a job wonderfully executed. Thank you so much.
Thank you so much.
Could we have our next certificate, please? So that's the last announcement. This is the certificate of appreciation we would like to present to Shushti Champaneri, and Shushti is an undergrad student from Terna Dental College, and this child relentlessly helped us in creating a logo and putting our thoughts and ideas together in a pictorial form. So thank you, Shushti, so much for bearing with all of us all together and coming out with this wonderful logo for which we get appreciations every day. Thank you.
I'm really glad.
Thank you so much. And with that, I'll hand over the session to Dr. Shelley to take over. Yeah.
Thank you, Dr. Priya. Now it's time to almost end the webinar and award our presenter and the chairman. First of all, I would like to award the certificate to the presenter, Dr. Anirudh. Can we have the certificate on display, please? Certificate to Dr. Anirudh. Thank you, Dr. Anirudh, for such an insightful and interesting presentations on a very special topic. It was really good presentation. Can we have the certificate, please? Yes, here you are.
Thank you.
Yes.
Thank you so much. Thank you so much, Shelley, and thank you, FSCD. It was my privilege, my honor. And this will always be special to me.
Thank you so much. We were so honored to have you and put all this across in a very simple way, and letting everyone know that things could be dealt at a very, very initial and a simple level. And with that, I would really like to say that periodontists have a major, major role to play. I think who can better execute oral hygiene prophylaxis than periodontists? So we really need to have them around.
Yes, thank you. So our next certificate is to Dr. Kumar sir. Thank you again, sir, for your valuable time and valuable input to this webinar, and also for chairing the webinar.
Thank you so much. Thank you so much. I've really enjoyed this session, I must say. Congratulations, Priya, for the concept and the ease with which you carry on these programs. There's so much to learn from you. God bless, stay safe, and anytime, I'm just a call away. Thank you.
Thank you so much, sir. It was a really honor to have you around, and getting an insight from you was really, really valuable to us. So we look forward to have more of you.
Thank you.
So I would like to.
Yeah.
Okay, I would like to present Dr. Shaili Pradhan a certificate of appreciation. Thank you, Dr. Shaili, for taking out time from your busy schedule and being a part of us, though you know, reluctantly, but you've always tried to support us. And thank you so much for doing this for me. And I'm really honored to have you around. Thank you so much.
Thank you. Yep. Anyone?
There are few.
If I may, it's been ages since I mentioned a couple of words in Nepali. So I think it's the right time to say to Shaili. Ramro Shaili Dhami.
Thank you, Anirudh. I think you saw so many your like previous students having said saying thank you to you.
Oh yeah.
In the chat box. Thank you, Anirudh. So lastly, I would like to congratulate FSCD on your first birthday. And then I would like to request Kumar sir for the closing remarks for this webinar. Thank you.
Oh, there's still remaining something? Okay, fine.
Closing.
So, you know, the precious thing about today's webinar is that you got across to dentists who always had the feeling to reach out. You probably have given them some SOPs. You've given them an opportunity. You've given them a platform. And I'm sure that this should get more viral than the current pandemic, because the need of the hour is to reach out as fast as we can to people who are waiting for some attention. So once again, congratulations, Priya, to you and your team. Dr. Srinivas Garu, wonderful job. Continue the good work. And there are enough dentists in our country and in the subcontinent who will be there hand in hand to form the chain to make sure that we don't miss out a single mouth which needs special care dentistry. Thank you. Namaskar. Good night.
Thank you, sir. Now, I would like to request Dr. Priya for closing the whole session. Thank you.
Okay, at the outset, I would like to thank everyone who's around us and trying to help us reach our goals. Thank you, sir. Thank you, Dr. Shaili. Thank you, Dr. Anirudh. And it was a wonderful session. There are a few take-home messages that I would like to say from your presentation. I already mentioned I've just jotted down a few things when I was attending your presentation. I would just like to say that medications and lack of manual dexterity and physical impairments lead to multiple oral problems. So we should try looking into that and handling things according to the impairment. And if the medication is the root cause, we should try looking into the substitutes. Role of a periodontist cannot be overemphasized in this, and as they play a very, very important role in maintaining and teaching how to do the oral hygiene regimens. Oral hygiene visits should be made mandatory at the perio level, and even at with all the general practitioners. The oral hygiene visits should be mandatory, and care should be rendered, care should be customized as per the challenge seen in the child, or a disability seen in the child. The carer should be educated, and prevention, compassion, and empathy is of utmost importance. So be compassionate and be empathetic towards all your patients. Thank you.
So I think this is all. Thank you, Priya, for this opportunity. Thank you, FSCD. Thank you. Good night, everyone.
Good night. Bye-bye.